Living Transplant is a podcast that takes you behind the scenes of the transplant program at Toronto General Hospital with the goal to educate, inspire, and fuel your passion about transplant. I'm your host, Candice Coughlin. Thanks for joining us for Season 4. In this episode, I take you behind the scenes of the Ajmera Transplant Centre's second annual Education and Research Conference, where we heard about incredible science, clinical, and research aspects of transplantation. I was incredibly grateful to get to sit down with Samrat Ray, Adriana Roberta, Javier Solera, Lakshmi Kugathasan, Bonnie Chao, Laura Donahoe, Christina Lamb, and Lakshmi Rajendran to hear about their amazing research. First up, you will hear from Samrat Ray about his research in expanding the transplant pancreas donor using an ex vivo perfusion model.
I'm Samrat Ray. I'm a gastrointestinal and hepatobiliary surgeon from India, New Delhi, basically. And I joined the Toronto Organ Preservation Lab in October 2021 in Dr. Marcus Selzner and Dr. Trevor Reichman's lab here. And since then, I have been given the responsibility of carrying forward the legacy of this great lab, which has done like wonders in the past by establishing the feasibility of a very important, a very novel concept in the field of organ transplantation, which is machine perfusion. So this lab has done a significant amount of work and published some landmark papers in the past, which are widely quoted all over the world in liver and kidney transplantation. So with that idea in mind, the idea was to like kind of move it forward to in the realm of pancreas transplantation. So that's the responsibility which was given upon me by my supervisor, Dr. Reichman. And since then, it's been a wonderful journey working here on this expanding the realm of machine perfusion in the field of pancreas transplantation.
Can you tell me a little bit about that perfusion?
Of course. So, I mean, just to give a brief overview of what perfusion really is, because that might be the first question in anybody's mind. What exactly is machine perfusion? So in organ transplantation, as we know in North America, like there's a dearth of organs. Like, unfortunately, the demand of the organs is way more than the supply that is existing there. So in such a situation, every organ is valuable, and that's why we promote the idea of organ donation, which is one of the most noble act by mankind, of course. But having said that, every organ has its own limitations, and there are various factors which limit its applicability in transplantation. So in cases of vulnerable organs like pancreas, because pancreas transplantation is relatively a very new field in abdominal organ transplant. So pancreas is a very sensitive organ. Like, it is one organ where it's super sensitive to touch, it's super sensitive to handling. Really? It is a zone where most of the surgeons don't dare to actually enter. Like, many a times in the teachings of general surgery, it is said that whatever you do, just don't touch the pancreas. That's what, yeah. So it can flare up so much. So you can understand how susceptible it is to any kind of wear and tear and any kind of trauma. So in such a super sensitive organ, getting the most perfect organ for transplantation can be a challenge. Right. Because of which the discard rates of pancreas transplantation are very high, like the organ procurement, I mean to say. Like, compared to the rest of the organs, the utilization rate is as low as just 9%, as per as per the recent data by the Canadian Institute of Health Information in 2009, it was found to be shockingly as low as 9%. Wow. So in such a situation, as surgeons, we definitely face the challenge of optimizing the use of what we have. Right. So that's where comes the role of machine perfusion. In the normothermic machine perfusion, what we exactly do is, like, this concept has been very well established in lung, kidney, and liver transplantation. So the very idea of normothermic perfusion is to create an environment where you're making an artificial lung, an artificial heart, an artificial blood, an artificial source of an environment for the organ to actually sustain itself in something that very closely simulates the normal physiology of the body. Right. So a normal human body has a particular temperature, particular temperature at which the organs are going to function, a particular kind of a pH of the blood and everything. So based on that, the concept of normothermic perfusion actually came, where we decided that, okay, this looks like an organ which is marginally damaged. We are not very sure, we're not very confident in transplanting it by the looks of it or by the by the fact that it has been on ice for a very long period of time, and we don't, and or it has been from a donor who is more than 60 years of age, or a donor who had some underlying cardiac disorder, or a donor who was morbidly obese. So in
Right.
those cases, those grafts are marginal grafts or the extended criteria grafts.
Mm-hmm.
So machine perfusion, what it does is it aims to optimize these grafts by by giving it a supply of some nutrients over the period of the time in which the organ is kept on machine, so that over that period of time it starts simulating the physiology, and on top of it we are giving more and more nutrients, like making it as healthy as possible.
Right. Interesting.
So going by that concept, this idea was actually expanded to pancreas transplantation, that we keep the organ on machine and try to like keep it on machine for the time we think that it's producing normal pancreatic juices. The biochemistry looks fine. It looks like it can be salvaged in terms of the endocrine markers or the markers of the tissue injury. So that was the whole idea of expanding the concept of normothermic ex vivo perfusion in pancreas. The word ex vivo means outside the body. That's why it's
Right.
ex vivo. In vivo is inside the body. So since we are taking the organ out and we are keeping it in an artificial environment, simulating the human body outside of the human body, that's why it's called ex vivo perfusion. So that's the whole concept of normothermic ex vivo perfusion.
Wow.
Now, my project specifically deals with the kind of grafts which are not the usual ones. Like the most standard grafts that we use in organ transplantation are the grafts that we harvest from donors who have succumbed to brain death. Like their
Right.
heart is functioning normally, their lungs are functioning normally, but because of some accident or some trauma or whatever it is, they sustained a brain death. The brain is
Mm-hmm.
not functioning. They go into a stage which is called as coma, cerebral coma. So in those cases, the organs are functioning well. So as a result of which the grafts are good. So
Right.
those grafts are the least risk graft, so easily acceptable.
Mm-hmm.
So what I'm trying to do is I'm trying to see if we can now expand the use of this machine perfusion in grafts which have sustained very prolonged periods of cold storage. Like for example, I get a donor call from Vancouver and I
Mm-hmm.
fly there and
Mm-hmm.
I get the organ on ice. Suddenly for bad weather, the flight gets delayed, which is very common in Canada, can happen
Right.
in winters. And my organ is stuck with me for like almost 12 hours. So do I throw that in the bin or I
Mm-hmm.
can still transplant it is the question, because 12 hours is quite a long time.
Right.
And many of the studies have actually proven that if the organ is on ice outside of the body for more than 12 hours, it's definitively detrimental to the outcomes of transplantation.
Mm.
So keeping that in mind, we thought that why not try, like why not test the extreme. So what we did was we used, so for our experiments, just for the starters, like we do all the experiments in porcine models. So pigs are our patients out here, like we are trying to, because that's the
Mm-hmm.
phase one of the experiment. So we are replicating everything in the porcine models, and since pigs have a physiology very similar to humans, it's the
Mm-hmm.
closest resemblance actually you can get in the animal kingdom of all the animal models that we use. So it can be very easily simulated into clinical practice. So in the porcine model, we take the graft out from the donor and we keep it on ice for 21 hours
Wow.
in the storage solution, which is universally accepted, the University of Wisconsin storage solution that basically provides the nutrients to the graft while it is on ice. So we keep it at 4 degrees Celsius in the refrigerator for 21 hours. And we chose this cutoff of 21 hours because this is extreme. So
Mm-hmm.
we know that if the graft sustains this, it can definitely sustain something less than this.
Right.
So we started from like we went on a top-down approach.
Mm-hmm.
So for 21 hours, we keep the organ, and the next day we have another pig who's delivered to us. That's the recipient pig. So first we take out the native pancreas of the pig and render it diabetic, because if the pancreas is still there and you basically implant another pancreas, you won't know which pancreas is actually working. So we
Right.
need to render them diabetic. So we take the native pancreas out. That way the pig becomes diabetic.
Mm.
So right after that, we aim to transplant the pancreas, which we have taken out from the donor pig, which has been lying on the ice for the last 21 hours. So that was the control group of our experiment.
Interesting.
So five of the pigs were transplanted like this, and remaining five were the test group. So the test group were the ones where after 21 hours of cold storage, we placed the grafts for 3 more hours on normothermic machine perfusion to artificially give them the nutrients that they need and to simulate the normothermy or the physiology outside of the body.
Mm-hmm.
So After those 3 hours, then we transplanted the graft into the recipient pig. Now, when we compared the results, there was a definitive evidence, like which we have actually shown. So we have definitively shown that in the test group, which was a normothermic ex vivo perfusion group, there was definitive improvement in terms of the graft function. Like we saw that 60% of the animals could actually survive for all the 3 days versus 0% in the control group. So that means in which it was only cold storage, all the animals died. Like they could not stay beyond one day. But in the ones where we did a normothermic perfusion, we could successfully keep the animals alive for 3 days. And besides that, on running a battery of tests, we found that the endocrine function, which is basically the glucose tolerance of the pancreas, which is basically the definitive test to say whether the pancreas is working or not, that was absolutely perfect in 80% of those cases, which in other words is a conclusive evidence to the fact that normothermic ex vivo perfusion seems to kind of reanimate or salvage these grafts, which have been actually damaged by the prolonged cold storage.
Wow.
So that way, it's a very, very promising thing, like the initial results. I know like we have a long way to go from here because it's just the initial step that we have taken. But it opens a lot of avenues for a lot of questions. That means a graft which was definitively damaged by cold storage, we could kind of make it alive again. It's more like a rebirth of the graft by using the normothermic ex vivo perfusion. And if that really works, and if that's a reliable method, you can imagine like it's going to be a boon to the field of organ transplantation. Like significantly, all the organ utilization rates in the field of pancreas transplantation is going to go up. So that's the whole idea of taking the realms of normothermic ex vivo perfusion in pancreas.
Brilliant. Wow.
Yeah.
That is really exciting to think of. Yeah, we think of the small amount of organs that are actually able to be used for transplant. And so thinking about that, how that could expand that donor pool in, making those pancreases fully functional again to be transplanted. So would the goal be to always use the ex vivo machines, or is there some instances where you have the ability to transplant the pancreas, even if it's slightly damaged, into a patient and it still work very well?
So in the clinical setting, the category that you're talking about, where it's slightly damaged and can still be transplanted, are called as the donation after cardiac death donors. So that's basically one of the marginal category of donors, which in our clinical practice at TGH, we have been transplanting. In fact, recently I compiled the data of 20 years of pancreas transplantation at Toronto General Hospital and found out that like in the last few years, nearly, almost 30 to 35 of the donors out of 600, like since 2000, I believe, were actually from the DCD donors, the donation after cardiac death donors. So the numbers are small, but they can be transplanted, of course. That's where you basically see many other factors, like which is called as a donor recipient matching. Like if they are, suppose they are retrieved from a donors who have succumbed to cardiac death, that itself is a risk. So you can't afford one more risk factor in that. Right. Like if that donor is also somebody who is 70 plus, then I don't think you're going to use that graft because that multiplies the risk manifold. Like if it was liver transplant or kidney transplant, there significant amount of progress has been made in this field. But in pancreas, it's still very new. There are hardly any centers actually who are doing such huge numbers of pancreas transplant in the world, for that matter. Yeah. And if we talk about normothermic perfusion or machine perfusion in the field of pancreas transplantation, Canada is definitely one of the world leaders, Toronto specifically, and it's definitely making its mark on the world map. Yeah.
That's really exciting to hear. Yeah. And, having you explain this to those of us who are not in this field, thank you for doing that, because it is a very fascinating thing to think about, the options that are coming forward to support people who are waiting for donations. So that's really interesting. And I'm wondering if there's anything else in your research that you think people would be interested in learning, or if there's somewhere that they could read about that research that you're working on.
Yeah, in the last ever since I've joined this lab, we have had a few good publications of whatever research we have done, even though we are relatively new in this field. But as I told that, like, as I mentioned this to you, that we are the only center in the world who are doing, normothermic perfusion in porcine survival model. Like besides us, it's France and Oxford in the UK who are doing some good amount of work. But having said that, we are still the only center who are doing survival models in pancreas transplantation. So we have had an amazing article which was written by one of my predecessors out here, Dr. Laura. She's from Germany, and her article was on establishing the feasibility of normothermic perfusion in pancreas transplantation. So that was the phase 1 of our study, and that was published in American Journal of Transplantation in 2022. It can be very easily accessed. And we have also published a recent article on the use of normothermic ex vivo perfusion in discarded human grafts, because as a parallel part of the project, we are also running this project in the grafts which have been discarded. Like they go on retrieval operations and they get the graft. If they think the graft is not suitable for transplanting, then it basically is discarded. So we are using those grafts and trying to put them on machine just to see in an artificially simulated environment. We keep them for 4 hours and we see with a battery of biochemical tests if it really works. So we have had really good initial promising results in a series of like around 11 or 12 cases. And we have published that in the recent edition of Transplant International by the European Society of Organ Transplantation. So these are some of the sources which definitely the audience can refer to. Besides that, like whatever I have told you about, it's in the process of definitely getting published, and keeping our fingers crossed, we hope to see it getting published very soon. And also, apart from that, there's another very interesting part of the research that our lab is getting involved in, is we are also trying to find out the genetic signature of like the molecules or the genes which are actually implicated in causing this kind of an injury. Because after we transplant an organ, like right after we transplant the organ, and it's basically a foreign organ to a body, right? And it has been lying outside of the body without any blood, which is called as ischemia, for a period of time. So after we transplant it, there are a lot of like immune mediators which are released in response to the blood flow. So that leads to a fulminant kind of a reaction, which is called as an ischemia reperfusion injury. And that's the key cause of causing any kind of graft damage anywhere, like depending on the severity. So in pancreas transplantation, I mean, no prizes to guess. The ischemia reperfusion injury is very severe. So we are trying to isolate some of the genes from the tissue and see like what are the genes which are actually overexpressed or underexpressed, which we could potentially target as a therapy. So if we know those genes and we can target those genes as a therapy, then after transplantation or during the transplantation, if we give those drugs to the patient, that might kind of theoretically suppress this kind of a reaction. And your post-transplant course will be much less fulminant than expected.
Right.
That could pave the path of a potential gene therapy. So that's definitely, I mean, we could achieve some significant initial promising results in that as well.
Fascinating. And that is definitely music to the ears of us recipients as well, to think about that, right?
Exactly.
Phenomenal. So I'm wondering, timeline wise, what do you think for the future of perfusion for pancreases? Is this research short term that you think within the next couple of years this will be used on humans, or is this more of a long-term process that may take quite a while before it's being used in humans?
Realistically speaking, it will take some time for sure, because I mean, like I said, in lung and in liver and kidney, they are like, I mean, at Toronto General Hospital, we are a part of the METRA trial, which is basically normothermic perfusion in liver. So the OrganOx trial. But then for pancreas, it's still a long way to go. But the initial promising results that we have seen, that is definitely opening up a lot of avenues. And it's giving courage to most of the transplant surgeons to actually consider machine perfusion in pancreas transplantation. Because otherwise, so far, like I told you, the story was either you accept it or you discard it. And the acceptance was just 9%.
That's wild.
But looking at the amount of diabetes, which is increasing worldwide, we cannot afford a 9% utilization. We need more than that. And pancreas is an organ where you can't even do a living donor transplant. It has to be from the dead donor.
It has to.
So, I mean, so that kind of limits our, pool. So having said all of that, we are definitely working very hard, and we are sort of optimistic that we might, like 3 years from now, I hope to talk to you again.
Yeah.
And then I mean, I hope to like give some more promising results to the world or to our listeners.
Yeah.
So that, yeah.
And when we think about, medical history, 3 to 10 years is a very short amount of time for something that big to make such a change in our medical lives, right? So
exactly.
Yeah, that's phenomenal to hear.
Yeah, exactly. And going by the pace at which things are going, like running, I mean to say, while be it at our institute or like in France or in UK, like we are working in close collaboration with those guys. It's definitely very promising, and people are working very hard towards it. And these collaborative efforts are definitely going to bear the fruit in near future, for sure.
Incredible.
Yeah.
Is there anything else that you want to leave our listeners with?
I mean, I would just leave with the message that, like, keep up the idea and the spirit of organ donation. That's the best gift you can give to the mankind. And
Amazing.
that's the most noble act of kindness towards mankind. So, I mean, I would just encourage everybody to consider organ donation, because nothing can be more noble than that.
That's beautiful. Thank you so much for joining me today and for sharing your incredible research that you're working on. So thank you so much.
Absolutely. And I would encourage like whosoever is listening to this, they should like definitely reach out to us if they want to. And if there are any students who are interested to actually be a part of the lab and just come and have an experience with us, they're more than welcome. It's definitely going to be an experience of a lifetime. I can vouch for it.
Next, you will hear from Adriana Roberta about mismatches, which are located in the DQ locus, and the development of chronic rejection.
I'm Adriana Roberta. I'm from Costa Rica. I did my fellowship here in the Ajmera Transplant Centre during 2022, and now I'm a clinical associate in the team. I work with the lung transplant team, and I'm very happy to be here and join you today to explain a little bit of the research that I have been conducting with my tutor, Dr. Roberta, and also with the rest of the team as well.
Amazing. So can you tell us and our listeners a little bit about that research that you're doing?
Yeah, of course. I can drive you through my research. So basically what we have seen in the past is that the patients that have certain differences in the HLA between the donor and the recipient are more prone to develop de novo DSAs. And of course, this can impact their performances in terms of survival and clot development as well. So basically, the objective of our study was to determine the impact of certain mismatches, which are located in the DQ locus and the development of chronic rejection, basically. And we hypothesized that the patients with DQ alpha mismatches, or the presence of risk epitope mismatches, which basically is defined as a specific mismatches in the DQ alpha and DQ7, have significantly reduced clot-free survival compared with the patients without these mismatches. So basically, we took all of our transplant population between 2014 and 2019, more than 19 years old, and with a complete cross-match data at the moment of the transplant. And also it was very important to be the first transplant only. And we removed those that has basically no DSA testing beyond the 14 days of the transplant, and also those with DSAs at the moment or prior to the transplant. So in total, our population were 687 patients. And these patients, we divide them in 4 different categories. Basically, we try to think of these in terms of going from less risk to more risk. And we stratify them in green category, which is the less risk, which means no mismatches at all. The yellow category basically only has patients with DQ alpha mismatches. The orange category only has patients with 1 risk epitope mismatches. And the red category, of course, is the highest risk, and it was composed by patients with both DQ alpha mismatches plus one risk epitope mismatch, or both risk epitope mismatches.
Okay.
Yeah. And basically for our outcomes, what we tried to see was the novo DSA free survival, which means how much time after the transplant the patient is spent without developing new antibodies against the new lungs, and also the free survival in terms of no chronic rejection. And we did this analysis basically using an unadjusted Kaplan-Meier estimate. And actually, when we compared the 4 cohorts, they were pretty similar in terms of the diagnosis, the sex, and also the age and the allocation status, which means the urgency to have the transplant, and also the type of transplant in terms of single or bilateral. So actually, there were no significant differences between them, but it was very interesting that we find, as we expected, that the red population, the one that had like the more mismatches, were the ones that developed more de novo antibodies against the new lungs. So we were able to confirm that. But the bad thing is that we were not able to confirm that these de novo antibodies cause more chronic rejection. So actually, it was pretty similar, the chronic rejection between the 4 different cohorts. So basically this drives us to the idea that something else is happening there, and we need to dig deeper to see if that's related with some infections or some rejection episodes or some different medications that we are using in this patient, patients that cause like the 4 cohorts to merge. And even when we analyze like the 3 cohorts with mismatches versus the one that is free of mismatches at all, still we found no difference. So we think something else is going on in there, and we need to dig deeper in this group to find out what is going on, so we can find a way to prevent that and have better results, basically.
Okay, interesting. So for people who are listening who may not be as informed about the HLA compatibility, can you explain a little bit about what that process is like for a recipient and a donor?
Yeah, of course. So basically, all of us, like the HLA is part of who we are, is our genetics. So we receive like on each, like a part of the HLA is based on mom, on the mom part, and the other one is based on our dads. And the combination of those two is who we are. So it's so when we want to have our recipient typing, we just ask to the HLA lab to analyze like who these patients are in terms of the HLA. And basically we have 2 different kinds of HLA, class 1 and class 2. And we analyze both for lung transplant. Both of them are pretty important. It's not the same for other organs, for example. And one important thing is, for example, when you think about a bone marrow transplant, you try to match the patient's HLA. You have to try them like very similar, but actually in our lung cohort, we do not match the HLA. So even if it's completely different from donor to the recipient, we will still do the transplant. So basically what happens is when you put the new lungs of a different person, like in the recipient body, of course, the recipient can see that the HLA is different, and it can start an antibody response, basically, right? What drives us to think this is because we have seen that the patients that develop antibody after the transplant, and specifically the ones that are against the class 2 HLA, sometimes develop more CLAD, like more chronic rejection, and they sometimes do worse than, and that's why basically drive us to all this study, basically.
Okay, interesting. And so why would you transplant someone with different HLA for a lung versus not being able to do so for bone marrow?
That's basically because, like for bone marrow, like you need like you are putting like the whole bone marrow in a different patient, and it will like the body of the patient probably will go crazy recognizing all these new things and will cause like a dramatic rejection. But for the lungs, even the lungs are really misbehaved compared with the other organs. We have ways to immunosuppress them and like try to shut them down a little bit and try like to prevent the lungs to recognize like these new lungs, basically, with these new HLAs. But the thing is, sometimes it happens that the body will recognize them and will start producing the antibodies. And sometimes we can do, like if they are having like a dramatic antibody rejection against the HLA, we can do certain treatments for that. That's what we call a antibody-mediated rejection. And we can like do apheresis and remove the antibodies. And we can also like provide other strategies, pharmacological strategies like IVIG and steroids, and also sometimes thymoglobulin. But sometimes the patients develop these DSAs and it's not strong enough like to provide like the full treatment and their lung function is stable. But we know for sure that certain DSAs correlate with worse clade-free survival, which means like they have worse chronic rejection-free survival, basically. So that's in these patients that do not have like the full AMR treatment, but had these de novo DSAs, are the ones that actually, that's part of the idea of the group. If we are able to find a correlation, maybe we can allocate organs based also on the immunological part as well, to prevent some kind of mismatches in the future.
Wow, that's fascinating. And so if you were able to do that, would somebody be able to take less anti-rejection medication?
I think it's hard to say that right now, because you have to prevent, like the lungs, as I was saying, are very misbehaved compared with the rest of the organs. So I will be very afraid to give less immunosuppression to our patients, but it's something that can be explored for sure.
Interesting. Is there something about your research that is coming up or that you want people to learn more about? Or is there anything perhaps that you would want to share that somebody could go and look up and read about?
Well, I think basically with HLA and the novel DSAs and acute and antibody-mediated rejection, still an area for all the lung transplant team that we are trying to work more on that, because it's a very like not clear still, and we need to work further like to find definition that all the transplant around the world agrees on, and also a treatment that we can agree on. So what I can advise people is to stay alert, because a lot more is coming about this. Everyone around the world is working very hard to try to optimize the treatment and have a more clear strategy to manage these cases, basically.
Amazing.
Thank you so much. And thank you for the opportunity to share.
Javier Solera speaks next about his research in the severity of COVID-19, Omicron variant, and Omicron-specific immune responses in solid organ transplant patients.
My name is Javier Solera. I'm a transplant infectious disease clinical fellow. I come from Spain, from Madrid. I was trained there in infectious disease, and I decided to come here because this is a great hospital, especially in transplant. It's a huge opportunity to be able to train to really big names in the world of infectious disease, in transplant infectious disease in this hospital.
Amazing. Thank you so much. I'm wondering if you can tell our listeners a little bit about what you presented on our research day and describe to us that work that you're doing.
Of course. So our research is focused on the impact of COVID-19 in transplant recipients, because everyone knows about COVID-19. It's like something that has changed our lives, everyone's life. But in transplant especially, we think that you need to take immunosuppressive therapy to prevent the rejection. The body is in high risk for a severe COVID-19. So our aim was we wanted to know how the transplant recipient respond to different treatments and different prevention measures, like for example, the vaccines. And we wanted to know how clinically, how they do with the COVID-19, how bad is the infection, how can we improve the prognosis of the patients. So we started since the beginning of the pandemic, back in March of 2020. We started collecting the data of every single transplant recipient that got diagnosed with COVID-19. And what we do is we analyze that data. And apart from that, sometimes a new treatment appears or a new vaccine approved, and we analyze how patients respond to these different interventions. For example, recently, we are analyzing how good the new bivalent vaccines are doing on our transplant patient. And we are, of course, analyzing now that we have already 3 years of COVID-19. We are analyzing how good has the transplant people done along these 3 years.
And so what does some of those data pieces look like? I know from a recipient perspective myself as well, COVID was definitely the scariest thing that we have faced, for sure, outside of, I would say, the actual transplant ourselves, right?
Yeah.
A lot of us went into our homes for a much longer time than the general population. And there's still a lot of fear out there for those of us transplant recipients. So I'm wondering, thinking about the outcomes, has there been a difference between the beginning of the pandemic, how transplant recipients were doing compared to now with our vaccines?
Yeah, actually, this is the most important question. Is we are doing better now than before? It's working, the intervention that we are doing? And the quick answer is yes. If you compare the outcomes now and the outcomes back in previous waves, every single severity outcome, if you compare the hospitalization rate, the requirement of oxygen, or the admission to the ICU, or the death, the numbers are decreased progressively.
Great.
So it's less severe than the previous one. And actually, it's an interesting question to do because of the virus is changing and now it's less severe than before, or because all the intervention that we are doing. We know for sure, because we have analyzed in multiple sets of population, we have analyzed the impact of vaccination. And we know that vaccination is by far one of the most important interventions that we can do. And that's why it was such a thing in the COVID pandemic to really strongly recommend the vaccination to all the transplant recipients. One of the most impactful papers published in medicine, in transplant medicine in the last few years, was the study that we performed in this hospital about the use of the third dose of the vaccine. Because before that study, the recommendation was to give only 2 doses to the transplant recipients. But what we saw is that with 2 doses, it was not enough. The transplant immune response, the immune system is not strong enough to respond to 2 doses of the vaccine. And, however, with the third dose, the response was much higher. And after that, we have analyzed multiple consecutive doses. And we can say that we have found that the immune response is better with the next doses, but it's not as important as receive the third dose from the second dose. Like, the third dose was the key for the transplant recipients. And actually, we don't consider anyone vaccinated if they are not have at least 3 doses. 3 doses is the limit for consider a patient vaccinated.
Fascinating.
Our recommendation, of course, is boosters doses of the vaccine. We are doing now an analysis of the efficacy of the last bivalent boosters. That is not published for the moment, so it's cannot say. But for the moment, I can say that the boosters are very important to give immunity against the variants that are designed for. So, for example, the last boosters are good for the variants that are included in the booster. It is true that the new variants, for example, the last bivalent booster include the original COVID-19 and the Omicron BA.5 variant. So this booster is quite good to prevent infection by Omicron BA.5. But we know that the new variants that are called BQ1 or XBB, so very difficult names, but we know that these variants are quite good avoiding the immune system. So it's difficult to prevent the infection in these cases. However, even if the infection is not prevented, we know that the outcomes are much better.
Amazing.
So sometimes the people that is against vaccines says, I received the vaccine, but I'm still getting infected.
Mm-hmm.
And one thing that is important to know, is that prevent an infection by a respiratory virus, COVID-19, is nearly impossible.
Right.
Even with the flu vaccine, you don't want to contagion because it's so difficult.
Mm-hmm.
You want to prevent the severe disease.
Right.
Because you are giving like a weapon to your body to fight against the virus once your virus is inside.
Okay.
It's nearly impossible to create a shield that completely prevent infection.
Right.
But we can give the tool to the body to fight the virus once you have the virus inside. So this is mainly the aim of the vaccination, and that's why we are so strongly recommending it. And we keep seeing in our analysis that people that is vaccinated has better outcomes than those that are not vaccinated.
Amazing.
The important message is like COVID-19 is better every new wave. When we start collecting data, the rate of hospitalization was nearly 60% of the transplant recipients.
Oh, wow.
That had infection requires to be admitted to the hospital.
Right.
And now the admission rate is, the outcomes are better, the prognosis is better. So I can say, for example, that 12% is 5 times lower.
Oh my goodness.
But, even in the people that is admitted, less than half of those require oxygen. So even the important thing, because, the COVID-19 can be very severe if it affects your lungs. Because sometimes you can have diarrhea, you can have malaise, you can feel very fatigued. But if you breathe well, you don't require oxygen, it's not going to be a bad infection.
Okay.
And the oxygen requirement and the ICU admission and the mortality has clearly decreased. The mortality now in most of the transplant recipients is 0%. We are not seeing new cases of death by COVID in most of the transplant recipients. Of course, the lung transplant recipients are at higher risk of the transplant because, it's your transplant, the lungs are the ones that are exposed to the virus.
Right.
But even in lung transplant recipients, the outcomes has clearly improved. And now it's not like before, and the mortality is extremely low. So we are very happy. We are very happy.
Yeah, that's amazing to hear. I know, unfortunately, most of us do know somebody who either passed away at the beginning of the pandemic or, had very severe consequences to getting COVID. And I'm wondering, when we think about starting to become a society that accepts that COVID is here and that it's not going anywhere, similar to the flu, as recipients, what can we do to protect ourselves continuing going forward on top of getting a mask? Like, how often should we be getting boosters? Is there a schedule or is it very unique to each of us?
Yeah. So those are excellent questions because are the important ones. That is, you need to keep living your life.
Yeah.
You cannot live in your isolation forever. So I always tell my patients that you need to understand that you have a condition like a transplant. So your immune system is never going to be as good as a patient that is not taking the medication that you need to take. But it's true that COVID-19 now, the prognosis is quite good. So you need to keep living your life. You need to think, like, of course, maybe it's not the most recommended thing to do to go into a very crowded area without mask, without washing your hands, because we still recommend use alcohol solution to clean your hands because it's very, very important, and use mask in crowded areas. But you can live a quite normal life. I don't think we need to fear like before, because before, of course, it was something that it was quite severe for transplant. And about the vaccines, the truth is there's no an agreement between the different societies. For example, the American Society of Transplantation recommend to give booster vaccines every 2 to 3 months to the transplant recipients to keep boosting the immune response, because we know that the mRNA vaccines works very well, but the effect decreases with the time.
Right.
The antibodies that your body is able to generate is with the months. It's something that is well studied. But the truth is, we believe that with the constant mutation of the virus, sometimes it doesn't make sense to give so many vaccines, because at the end you have reached some level of immunity in your body that is going to protect you against the most severe part of the disease.
Okay.
And as I told you before, you can give 7 doses of the vaccine that is nearly impossible to prevent the infection. So the infection, if it has to happen, it will happen. So actually the current Canadian Society recommendations are to give a booster vaccine every 6 months. I have to tell you that I believe that these recommendations are going to change, and you have to consider that new vaccines are coming. So there is a possibility that this turns into something more similar to the flu, as you said. And for the flu vaccine, you have a different vaccine every year. And it's a different one from the previous year because the virus mutates every single year and you need to generate a new vaccine. So with the COVID-19, probably is going to be the same. The vaccines that we are giving actually are not quite effective against the new variants because the virus is completely different from the previous one. So 3-4 doses of vaccine. The number of booster vaccine will depend with the time and with the new vaccines that are available. When they develop a new vaccine against the circulating variants, it's recommended to receive that vaccine. About the previous vaccines, there's no a good agreement because at the end, this is something that evolved so fast.
So fast,
that you cannot know everything. Like the science is, if you want to do studies to test everything, it's going to take longer than the COVID take to evolve. And that's the problem, that some data that you see published in the journals now are about patients that are infected with previous variants. So you are not sure of what's the correct thing to do. But I would encourage to receive at least, I would say 4 doses of the vaccine. It's a good number. And that's a good point because it's going to give your body enough immunity against the severe disease. And apart from that, then the recommendation of the number of booster vaccine will change with the time.
That's great to know, and especially helpful to know about the hospitalizations and deaths. I think that really helps for us recipients to breathe a sigh of relief that people like you are working so hard behind the scenes to keep us safe and to keep us protected. So on behalf of recipients and donors, thank you so much for all of the work that you and your team do, because you really did give us hope and you've given us the ability to come back to real life, because at the beginning of the pandemic, it for sure was a thing that we weren't sure when it was going to be or how we were going to be able to live in this new world. So the work that you guys do is just so important to our lives.
Thank you. It's a pleasure. I feel proud to be able to do research in a hospital as good as this one, and it's a true pleasure to be here.
Amazing. Is there anything that maybe I didn't ask you about that you would like to share?
I don't know. I would like to share hope with the people. The virus is still here. We don't know. No one knows what's going to happen with the virus. If someone tells you, oh, for sure the virus is going to be over in 1 year, don't believe him because no one knows. But the good thing is we know that the severity is every day is lower and lower. So the outcomes are better, and it's a reason to be happy.
Next, you will hear from Lakshmi Kugathasan about her systematic review and network meta-analysis research in induction therapy in heart transplantation.
My name is Lakshmi Kugathasan, and I did my PhD in the Department of Laboratory Medicine and Pathobiology at U of T. And over the last 4 years, I've been working with Dr. Alba as a cardiologist in the Advanced Heart Failure and Heart Transplant program at UHN. And her research interests span across a spectrum, where at one end, she is trying to better define the risk profiles of patients being diagnosed with heart disease through the use of risk prediction models. And on the other end of the spectrum, we are trying to understand ways in which we may improve outcomes for patients undergoing heart transplantation. And this relates to the work I recently presented at the Ajmera Transplant Centre's Research Day.
Wonderful. So can you tell our listeners a little bit about that research that you presented?
Sure, yeah. So my presentation at the Ajmera Transplant Centre's Research Day focused on a systematic review of existing scientific studies and analysis of data from these studies in trying to understand or address a controversy surrounding the benefit of a type of immunosuppressive strategy called induction therapy for patients undergoing heart transplantation.
Okay, wonderful. And can you explain a little bit about that induction therapy?
Sure, yeah. So I'll start off with a bit of an introduction behind the entire research. So heart transplantation is one of the last options in patients with advanced heart disease. Unfortunately, rejection of the transplanted heart is a commonly encountered issue and can occur within minutes of transplant or following years after transplantation. As our understanding of how our immune system works has evolved, so have the development of various immunosuppressive therapies to reduce the risk of rejection. So induction therapy happens to be one such immunosuppressive strategy, which is given around the time of surgery with the aim to minimize the risk of early rejection. While there are benefits to using induction therapy, there are also side effects that can result, including the development of infections and cancer.
Okay.
So, because of a lack of clear benefits with the use of induction therapy, due to there being a lack of adequate high quality data, we were approached by a heart transplant guidelines panel that was made up of clinicians, healthcare workers, and patient partners to analyze and summarize all the available data from the existing scientific literature.
What have been some of those results that you have found?
We did a systematic search of scientific databases to identify studies from the year 2000, which reported on the use of any induction therapy agent and any post-transplant outcome. And we evaluated both randomized controlled trials, which provide the highest level of evidence, and also observational studies using a methodology called network meta-analysis. The outcomes that we examined were mortality or death, rejection, infections, kidney dysfunction, cancers, and the onset of coronary disease, which is known as cardiac allograft vasculopathy or CAV. So apart from conducting a statistical analysis of the available data, we also evaluated the quality of evidence for each of these outcomes and presented these findings for the use of two of the most commonly used induction therapy agents known as Bacillus and ATG, comparing them to the use of no induction therapy or to each other.
Okay.
So in terms of a high-level summary of our findings, what we saw was that because of low to very low certainty in the evidence from randomized controlled trials, we were uncertain whether these two agents increased or decreased the outcomes that we assessed compared to no induction therapy or each other. And then looking at observational studies, on the other hand, we had low certainty in the evidence with some of the comparisons for some of the outcomes and saw that basiliximab may increase 30-day and 1-year mortality compared to no induction therapy, while ATG may decrease 5-year coronary disease compared to no induction therapy, and that ATG may decrease 30-day, 1-year, and overall mortality compared to basiliximab. So we took these findings and we presented them back to our panel, who then outlined recommendations following a discussion and suggested against the routine use of basiliximab and ATG compared to no induction therapy, but suggested that for patients in whom induction therapy may be desirable, so these may be higher risk patients, the panel suggested using ATG over basiliximab.
Interesting. What do you see yourself or your researchers doing in the future?
Oh, that's a great question. So I think what is really needed in this area is a more rigorously done randomized controlled trial to compare these agents, and more importantly, to also identify subgroups of patients who may selectively benefit from the use of induction therapy.
Amazing. Is there anything that perhaps I didn't ask you about or more about the research that you would want to share with our listeners?
I think it was just an honor and, absolute pleasure to be invited on this podcast. I'm immensely grateful to the Division of Cardiology, and in particular, Dr. Alba and Dr. Heather Ross, for the research opportunities, my co-authors, as well as expert methodologists at the McMaster University and the Ajmera Transplant Centre for organizing the research day. It was an absolute pleasure.
Wonderful. Bonnie Chao speaks next about her research in machine learning approaches to processing and interpreting ex vivo lung radiographs and predicting transplant outcomes.
My name is Bonnie. I'm a fourth-year PhD student in biomedical engineering. I work with Dr. Gashapji, Dr. Bowen, Dr. Andrew Sage on some AI applications in lung transplantation. I'm in my fourth year of PhD, so yeah.
Amazing. Thank you so much for joining me today. I really appreciate it.
Thank you for having me.
I'm wondering if you can tell our listeners a little bit about that research that you presented on.
Yeah, so as mentioned, we work in lung transplantation, and specifically, we're trying to take in donor lung information and try and make predictions on recipient outcome post-transplant. In our group at Toronto Lung Transplant Program, we work on a system called ex vivo lung perfusion. It's basically a platform that aims to keep donor lungs alive outside of the body prior to transplantation. It is like our circulatory system in the body, kind of. So we have a fluid that flows through the lungs. The lungs kind of breathe on their own on their circuit. And we usually leave these donor lungs on the circuit for about 4 hours so we can take different assessments. And surgeons can better make decisions on these physiological functions, tests that we make on the lungs.
Fascinating.
Yeah, so the best thing about ex vivo lung perfusion, or EVLP, is that we can assess a lot of physiological functions prior to transplantation, and a lot of these tests would not have been possible without this platform. So we can measure lungs at their physiological working conditions, like the body temperature and pressure. We can measure functional assessments like compliance, basically the elasticity of the lungs, the pressure of the lungs, how well the lungs are exchanging gases, how injured they are by how much fluid they're accumulating. We can also measure biochemical and inflammatory signals like pH, electrolytes, glucose levels, inflammatory signals like the inflammatory proteins or gene expression. So there's a lot of measurements we can take just by having the lungs outside of the body and kept at physiological conditions. So my research focuses on the imaging part. We take these X-ray images of the lungs outside of the body. So different from traditional chest radiographs, these X-ray images are just the lungs outside the body. So we don't see obstructions from chest wall, ribs, or heart. We just see a pristine view of the lungs with vasculature, individual lobes. Yeah, so in my research, we want to look at whether this radiographic information of ex vivo donor lungs is informative in surgeons' decisions to transplant or decline the lungs. And previously, we've already worked with a radiologist to go through about 200 images from our EVLP subset, basically looking at these ex vivo radiographs and trying to see what he can actually visibly see from these images and correlating these findings with poorer recipient outcomes. But the caveat of that is we would have to always work with a radiologist, which is a bit of a limitation because most EVLP or most lung transplant centers don't currently work with a radiologist. So we wanted to build a algorithm that can kind of act as a virtual radiologist in the room, EVLP room. So the algorithm, ideally, it would read the images and output as much information about the images as possible for the surgeons. Yeah.
That's really cool.
Yeah. So usually we take 2 images at different time points over the course of 4 hours. And what we did was we concatenated the 2 images into basically one, I guess, larger image to make one classification. Yeah, so each case would have 2 images, and we would make one single classification based on the 2 images together. And our classification, there are 3 classes. Basically, we're trying to see if the lungs would be declined by the surgeon, if the lungs would be transplanted, but with a longer extubation time from the recipients, or if the lungs would be transplanted with a shorter extubation time for the recipients. And I guess in simpler terms, you can see these 3 classes as declined lungs, transplanted lungs with worse outcomes, and transplanted lungs with better outcomes. So yeah, those 3 classes are the ones we're trying to classify for. And in total, we have 650 cases, 1,300 images. Wow. And we were able to get a pretty good classification accuracy. We were able to get like a 76% accuracy when we classified for these 3 classes. And if we simply classified for a transplant or decline decision at the end of EVLP, then we would get a 90% accuracy. Wow. So it is working pretty well. And we found no significant differences between this approach, this computer vision approach versus the radiologist manually labeling approach predicting outcome. Wow. So that is pretty encouraging. And as I mentioned earlier, we also take these other functional assessments, like the physiological, biochemical, and inflammatory signal during EVLP. And we previously worked on a study classifying the same outcomes using these, we call them tabular data. So these are data kind of in a table structure, pH level, 5.8, something like that. So we took all those, I guess, numerical data to perform the same classification, and that returned an accuracy of 72%. And when we found that when we added these images as input to the tabular data modeling, we were able to increase the accuracy by 6%, which is very, very significant statistically.
So people who are listening, I mean, we've heard a lot about AI doing a lot more in the medical field. Thinking about being able to use resources like this to classify things, do you think this could have broader reach in things that could support physicians in being able to diagnose certain things or use it for medical imaging, maybe for those types of?
Yeah, so in terms of images, it can definitely be applied to other forms of diagnostics. So ICU or ward, or even just incoming patients. In some countries, they don't have as many physicians or radiologists. So this can really help facilitate the workflow. So the algorithm can flag the images that seem to have a problem that would then prioritize these images for the radiologist to look at. In terms of other medical data, like those tabular data, like our physiological assessments that we usually take, like blood tests in ICU or ward, those people have also made really cool models kind of monitoring these ICU or ward patients and flagging the ones that could potentially deteriorate in the next 24, 48 hours, etc. So it can really help physicians focus on the patients in need. And a lot of really cool applications for sure.
And then thinking about the ex vivo perfusion with lungs, has that been used on patients already, or is this still in the processing and testing area?
Yeah, so we got our FDA and Health Canada approval in, I believe, 2012 and 2013. So this is a, I guess, clinical application that's been actively used regularly. We get about 2 cases per week. Generally, only the donor lungs that are marginally acceptable are put on EVLP because it does incur extra costs on the healthcare system. So if the donor lungs are obviously healthy, they get directly transplanted. If they're obviously injured, then they get declined. Only the ones that the surgeons aren't so sure about go on EVLP. Yeah, and EVLP is a good platform to help the lungs repair themselves, because when the organ is at a physiological condition, the tissues are able to self-repair. And furthermore, we can administer antibiotics and other potential treatments like cellular treatments, gene engineering to like repair these lungs before they're transplanted.
It's so cool. Yeah. So thinking about your research, is there anything perhaps outside of what we've talked about today that you think people would be interested in, or something that maybe I didn't ask you about?
I guess there's always a lot of discussions on implementations and ethics, biases when it comes to AI in medicine. It is a very important topic. Technically, a lot of these problems are not easy to solve, but a lot of us are trying. Deep learning still remains as a black box in most applications. There are interpretation methods. They are not everything. They are limited, but it's a very important area of research in medicine, especially when you want to know exactly how like we can trust the models and how much like we can apply it like across different centers. So that's like a important but difficult part of research, because deep learning, one reason why it's so powerful is that it can take in so much data at once and process it internally. And there's just not really a effective way as of now to kind of open the black box and see what it's actually doing to these data. So it's hard and we're not there yet, but I think having AI applications in medicine will really help push this aspect of research, because it's probably more important in medicine or healthcare than many other fields.
For sure. Interesting. And it's amazing to know that people like you and your team are working really hard and advancing this. It's super cool to get to listen to you and to hear about what your team is doing. And so thank you so much for giving us the opportunity to kind of get a look inside and behind the curtains of your research.
Yeah, thank you so much. That was a fun interview. It was fun to talk about my own research as well.
Next, you will hear from Laura Donahoe and her innovations in improving the quality of lung transplantation through a technical skills simulation program for surgical lung transplant fellows.
My name is Laura Donahoe. I'm one of the thoracic surgeons and lung transplant surgeons in the Ajmera Transplant Centre. I'm also the fellowship director for the lung transplant surgical program, and I'm the program director for the thoracic surgery residency program.
Amazing. And can you tell our listeners a little bit about that research that you presented?
Yeah, so my research interest is in education of surgical trainees. So the traditional model of learning how to do surgery is that we practice on patients. It's really an apprenticeship model. So you start as a junior resident, start by watching, you learn the steps of the procedure, and then it's a gradual increase over time in terms of how much responsibility you get during the surgery, how much you get to do. It's always overseen by the staff surgeon, but really it's a graded responsibility and graded increase in the difficulties of the tasks you're asked to be doing. In lung transplantation and in any type of transplantation, so it's the same for liver and kidneys, hearts, it is a subspecialty of an already established surgical specialty. So for instance, we train as thoracic surgeons. That means I've done 5 years of general surgery. I then do 2 years of thoracic surgery. And then I did an extra year to learn how to do lung transplants. Wow. Part of which was lung transplants. And this is the same for across surgical specialties. It's extra training in addition to your training that you do to become a certain type of specialty surgeon. So these are very, very highly trained people that we're teaching how to become surgeons in transplantation. And we know that these trainees, these fellows, a lot of them have been practicing as staff surgeons in their own countries, and they come in, from all over the world to train in the Ajmera Transplant Centre. And so what they need to learn here is very different than what, say, a junior resident would need to learn when doing a surgery. So for our senior trainees, they need to learn things like how you sew the lung in. They don't need to learn the basic anatomy of the chest. They already know that. They've done all that training. They've, established their competency in that. But my educational research focus is on teaching these very senior trainees how to learn how to do transplant surgeries and trying to teach them outside of the operating room. Okay. So over the course of the past number of years, there's been a lot of research on simulation and what's simulation in medical education, and it's used in a lot of other different areas, such as, in the aviation industry, they do a lot of simulation. basically it's practicing a task outside of the situation where you would usually do it in order to learn in an environment that's low stress, has no consequences. And so you can learn a lot of the information that you need to know when you're put in that situation in real life.
Right.
So in surgery, there's a lot of simulation research that's been done learning how to teach people surgical skills outside of the operating room. But what I did a master's in health sciences education a few years ago and learned that really a lot of the focus on simulation is in junior learners. So again, back to those junior residents who need to know just the steps of the procedure. And I realized that for our very senior learners, that's not really what they need to learn. And simulation to teach them the steps of something isn't probably going to be the most important way or most important thing for them to learn.
Right.
So my research has been focusing on creating simulation models or things to practice on that would then be very similar to what it's like in the operating room so they can learn the specific skills that we need them to know to do a lung transplant.
Wow. That's fascinating. So these are the people who are coming through who have, lots and lots of experience, but are now looking to be highly specialized in that surgical realm. So what do those simulations look like for these people?
Yes, that's exactly right. So very highly trained. So what we've been working on is creating models for each of the steps of doing a lung transplant. So it's a pretty simple concept to do a lung transplant. You take the lung out and put the new one in, and you have to divide the artery, the veins, and the bronchus or the airway, and then hook each of those structures back up. So we've been working on coming up with an artery model that's very similar to what an artery would feel like in the operating room, but using other materials such as silicone. We're looking at different recipes basically of coming up with materials that might mimic what it's like in the operating room. We've created a bronchus so that the airway anastomosis, her hookup, is very similar to what it's like in the operating room. And we're working on the veins. And the steps are very similar, even though it's different structures, but it's a similar concept for most of the types of transplants. So with the heart, it's similar vessels. They have to also sew the pulmonary artery to hook the heart back up. They have to sew, the inferior and superior vena cava, which are a little bit different texture, but the same idea of sewing them together to put the heart back in. So there's very similar across all organ groups in terms of what these fellows need to know.
Wow, that's really cool. And so this has begun, these simulations have begun already?
Yes, it's a work in progress. I'm
Okay.
working with a surgeon out of Boston and then an amazing PhD student, Kate Kaslovich. So we've been working on developing these models. We've created a box. We call it the Marshall 3 after Dr. Blair Marshall, who's a surgeon in Boston. It was her original design. And then we've been just slowly working on it over the course of the last couple of years to improve it. And then in the meantime, we have rolled it out to our fellows. So still working on developing a formal simulation curriculum, but our fellows each get a box and they get some arteries and they get some bronchi that they can practice with. And the other important part of this is that it's very difficult to plan anything when you're dealing with surgical transplant fellows because the life is so unpredictable. Right. So oftentimes I've planned a course or a session one afternoon, and then 5 of my 6 fellows are off on a donor or doing a transplant. Right. So the way we've done it, they can take them home, practice on their own time, and so they're already in use.
That's fascinating. And so what have you found, the people who have been using these already, what has the feedback been from them?
Our early feedback has been very good. We actually also had it last year at our thoracic surgery boot camp, which is a 3.5-day course that we run for all the first-year thoracic surgery residents in the country. We had our simulation boxes and models there, and we got really good feedback. The ultimate goal would be to show that practicing outside of the operating room actually improves the surgical skills inside the operating room and then improves patient outcomes. And that's sort of the overarching ultimate goal of simulation. But at this point, we're sort of near the beginning, and just know that our fellows have really appreciated it. We've gotten a lot of good feedback and are going to continue with it.
Amazing. And do you think this also builds confidence as well in them?
For sure. So in order to sew anything, you use what's called a needle driver. So it's an instrument that actually holds the needle, but there's different models of them. And we use one specifically in lung transplant surgery that's very different than many of them have ever used before. And it's a bit finicky. So having the ability for them to practice that outside of the operating room, just to learn how the instrument works, I think is very beneficial and I think helps.
That's fascinating. And do you see this growing in other areas as well? Could that potentially work for other transplants?
Yes, absolutely. I would love to expand this to other organ groups. We can definitely create something that looks like and feels like a bile duct, so that liver transplant fellows can learn how to, or practice how to sew in bile ducts outside of the operating room. So I think there's a lot of potential.
One of the other interviewees that I spoke with was about how sensitive the pancreas is as well. And just thinking about that, how interesting that may support people even in that realm of learning how to use different materials and things. I didn't know that the pancreas was that sensitive until I interviewed him as well.
Yeah, we like to, I no longer do general surgery, but I trained as a general surgeon, and that's, you want to stay away from the pancreas. That's what you learn. So I really admire the pancreatic transplant surgeons.
Yeah. Oh, that's so interesting. Yeah. And I'm a kidney transplant recipient. And so thinking about, all of these new initiatives that are going into improving care for patients, and, the passion that the team at UHN has to just make things better and smoother for those learning. It's really fascinating to hear. Is there anything that perhaps I didn't ask you about, or that you think would be interesting for our listeners to hear?
Oh, good question. I think it's important just to know that a lot of education does happen in other ways as well, but I think it would be really exciting if we could create a way to really teach everybody everything they need to know outside of the operating room. That's another kind of lofty goal, but and I know from a patient perspective, like when you hear that it's a teaching hospital and you have people learning, it is part of surgery and part of our model, but I just think that there's ways that we can improve it so that it makes it a better learning environment for the trainees, and then, overall safer for the patient, which is the ultimate that really matters.
Amazing. Well, thank you so much for joining me today and for sharing your amazing research. And I would love to see what's inside of that box. That would be really cool.
I'll definitely show you. Thank you so much for having me.
Christina Lamb talks to us next about the fibrinogen-like protein 2 molecule and how it influences the development of thymic regulatory T cells.
My name is Christina. I am currently a PhD candidate at the University of Toronto. I am part of the Institute of Medical Science department, and my lab is located in the Thoracic Surgery Research Center.
Amazing. I'm wondering if you can tell our listeners a little bit about what research you're doing.
Sure. So I'm a transplant immunologist by training. I try to understand the immune system and how that contributes to the process of organ rejection in transplanted patients. So my research project focuses specifically on a compound called fibrinogen-like protein 2, or FGO2. It's such a bad name, because it doesn't roll off the tongue. So if I'm explaining it to a non-science person, I always just call it the actor. That's good enough.
I like that.
Yeah. So this molecule is very interesting because it has been found to have a regulatory function in our immune system, specifically in a subset of cells called regulatory T cells. So as the name suggests, these T cells are able to regulate the immune system. So normally, in a healthy human, these cells, they play an important role in preventing things like autoimmune diseases, and also in controlling the immune system, so that you don't, just to prevent excessive damage on the host. So these cells are obviously really great interest in the field of transplantation, because the main problem that is playing and sort of hindering the field from advancing forward is the chronic rejection. With the rise of regenerative medicines and cell transplant therapy, a lot of people, specifically immunologists like me, are really interested in understanding how regulatory T cells can be used, and so that we can able to improve long-term tolerance in patients. So going back to the F factor, so this molecule has been shown to be used by regular T cell to regulate the immune response. But it was very interesting when I did my experiment. We found that it's not just the protein doesn't just regulate the immune response the way that we previously thought. It can actually control the development of regulatory T cells as well. And it was the most striking observation we saw was that depending on where the protein was coming from, it actually had opposing effect on regulatory T cell functions, which we thought was a very interesting, because for a long time this molecule we just thought to like really augment regulatory T cells capacity to suppress the immune response. We found that in my data, it can also downregulate the regulatory T cell as well. So it's sort of just like a built-in mechanism, so it's for the cell to also like control themselves, which is really interesting. So I mean, the ultimate goal, like this, like it just, trying to understand the biology of these cells so that we can move closer to the day where we can harness their use in clinical practice.
That's fascinating. I mean, I think for any of us transplant recipients, when we hear the word tolerance, we get really excited, because when we think about transplant, definitely our immunosuppressants are the biggest bane of our existence, right? Keep us alive. Yeah, they keep us alive, but they also have their own side effects too, right? So that's fascinating research. And so thinking about the future, what are your ultimate goals for this research?
I'm obviously, there are a lot of cells in the immune system, and I'm obviously very biased toward regulatory T cells. So I would like to just by furthering our understanding on how these factors actually modulate regulatory T cell function, I'm hoping that we can somehow use the information that we found to improve the regulatory T cell, maybe make them into like super regulatory T cells, and then really will augment tolerizing capacity and give them to patients.
That's amazing. Is there anything perhaps that I didn't ask you about, or that you didn't speak about, that you think our listeners would be interested in knowing?
Well, maybe this is not the right crowd because they probably already know this, but I always tell people that it is in Canada, it's an opt-in system for organ transplantation. So you can sign up to be an organ donation. I think it's like a check mark.
Yes.
And that will significantly help our organ donor pool.
Absolutely. Yes. Beadonor.ca, register your consent, talk to your family. Absolutely. That's the best advice we can leave people with. You're doing amazing work, and continue with that F factor.
Thank you so much.
Last up, we hear from Lakshmi Kugathasan about the Toronto management of initially unresectable liver metastases for colorectal cancer in a living donor liver transplant program.
My name's Lakshmi. I'm a fourth-year general surgery resident at the University of Toronto, and I'm very interested in transplant and liver transplant oncology.
Amazing. So can you tell us a little bit about that research that you presented at our education day?
Yeah, absolutely. So the research really focuses on living donor liver transplant as one potential option for colorectal liver metastases in a setting where it's unresectable. And so really it is kind of broadens what tools we have for that patient population.
Amazing. And so for that research, what you're doing right now is actually transplanting a portion of a liver to somebody who has cancer and then removing their liver?
Yeah, absolutely. So it's currently in a trial setting. So around 2016, the University Health Network, they adopted the living donor liver transplant trial specifically for patients that have unresectable disease. And really, patients who have been seen and screened and throughout the process are maintained on chemotherapy for at least 6 months and up until transplant, and have to demonstrate that their disease is stable. And there's a lot of factors that do come into play and making sure that they're still candidates. But then the patients that do end up being candidates for our trial and do end up getting transplant, we've shown that they have really good outcomes in the end.
Amazing. And we had Dr. Sapaso Chin and Natalie on our podcast last season, and they talked about their journey together, which was absolutely remarkable. If people want to listen to that episode, it's called James Bond and Cancer Muggles, which was really great to have them both on. So approximately how many people have been through this process so far in your research?
Yeah, so in total, about 106 patients have been referred, and this is kind of taken around the time of late February. And of those people, only 8 patients actually made it to transplant so far. So it is a pretty intensive screening process, and the median time to transplant from the initial consultation is about 15.4 months. So it's quite a long period of time. There's a lot that's involved, and it's a very select patient population that do end up going through and getting transplant.
For those people who did go through this process, what makes them eligible to be part of this trial?
Yeah, so we have a strict exclusion criteria, and some of that really involves patients who do not have a BRAF V600 primary. They have stable disease, meaning stable imaging findings and stable CEA levels, which is a tumor marker. And so they have to demonstrate disease stability. They have to be on chemotherapy, as I said, for about at least 6 months or so, and up until the point of transplant. They also can't have any extrahepatic disease. And it's also making sure that clinically, so patients that have other concurrent cancer or have had previous transplant do get excluded. And the other key thing is they do have to have a living donor. So all of those factors do come in. And we do see patients, so they receive regular oncologic screening or surveillance while they're along or on the trial. So every 3 months or so, patients will get CT scans as well as CEA levels. And if at any point, either they have disease progression, they have development of extrahepatic disease, or if they become resectable at any point, they are no longer eligible for transplant.
Wow. So it is a very strict process, a really tight group of people who would be eligible for that. From that group of people who have been transplanted, what have the outcomes been for them so far?
Yeah, so overall, the overall survival has been really great. So only one of the 8 patients has died, and the time from transplant to death was about 39 months. So it's quite an extended period of time. We did have 2 recurrences in the patient population, and of those recurrences, they were extrahepatic disease. One of them was an earlier recurrence after transplant at about 3 months to the lung, and that might have just been a missed metastases at the time. But when we compare them to patients who've had liver resection within our population who were excluded from transplant and instead were downgraded from their disease burden with the chemotherapy and then went on to have liver resection, the resected patients actually, almost all of them, so well over 75% of them did develop recurrence and within 3 years, versus the transplant population, the recurrence-free survival was dramatically better.
Wow. We know that there is a shortage of organs for the need right now, and that gap is filled by our living donors. Is that the reason why you only accept living liver donors? Why somebody couldn't have a deceased donor for this, or why you would have that as a requirement?
Yeah, absolutely, especially in Canada. In North America in general, deceased donors, we have such limited supply, and given the shortage, it's very difficult to extend the criteria to include this population, but specifically also through UHN, we're not able to use that deceased donor just from kind of the politics, the protocols that are established. So living donor does give you an option. And the other things too is with living donor, it also gives you an elective operation. You have more control over the timing of chemotherapy. And so you're able to kind of control when we stop the chemotherapy and give them some time prior to the surgery. So you do have a little bit of leeway that way. And we've also shown that living donor leads to better, if not at least comparable, if not better outcomes compared to deceased donor liver transplant for other conditions, such as HCC. And so I think it's a very great option.
And I mean, we never use the other C word when we're talking about cancer cure, right? Because it's a very difficult thing to think about. But when we think about recurrence of cancer and remission, from the 2 people that I've spoke to who have been part of this trial, they have been in remission since they had their liver transplant. And for them, often they will use that word cure, that they've felt that living donor transplant has so far cured their cancer from coming back. What does that do emotionally to somebody to know that this is a new opportunity? And have you seen that with your patients, that this is a new hope, I guess, for a treatment?
Yeah, absolutely. I mean, I think the goal is towards cure. So the idea really is to that hopefully the disease is just in the liver, that there's no extrahepatic disease. That's the patient population that we're offering this for. And so the idea is you're removing essentially the disease, the entire liver, you're replacing with a new liver that shouldn't have any disease. So in patients where there is no missed extrahepatic disease, hopefully that we are aiming towards a cure. And I think there is a lot of hope for both patients and ourselves as providers. I mean, I'm still in training. For me, it's obviously I'm not the one that's kind of directly responsible for like those patients, but at the same time, I've been involved in their care, and it's really, really great to be able to see those patients kind of in follow-up and see how well they've done, and not seeing them come back with any recurrence many years out. And so I think it does provide hope for both ends. And I do think that our goal at the end of the day is towards cure. And I think transplant is a great option, especially in this disease and patient population.
Amazing. And one of the questions that I get often, being a recipient myself too, we focus heavily on our immunosuppressants. So if somebody is receiving a transplant for their cancer, are they also on immunosuppressants the rest of their life, similar to the rest of us transplant recipients?
Yeah, absolutely. So they do continue on with almost the usual transplant immunosuppression protocol. Of course, with any cancer, you do have to be also careful with immunosuppression in the sense that you could also be at risk for recurrence of cancer. But it is still kind of a balance between making sure that there's no rejection, but also making sure that you're not reducing the immune system to a point where recurrence is a higher possibility.
An amazing balance that you guys are able to figure out. I know in the past I've called it my miracle cocktail that I take every day. Kudos to the teams and the pharmacists who figure all of that out, because it's far beyond me. But I'm wondering if there's anything else that maybe I didn't ask you about that you think our listeners would be interested in knowing more.
I think just in general, kind of as a summary, I would say that living donor liver transplant is a great option, but in a very select patient population. As we've seen kind of in our study, we've screened and really followed a large proportion of patients, and only a very select number of those patients do go on to have liver transplant. And so I think we do have to be very mindful in terms of selecting patients that are going to benefit, because you do have to balance out the risks and benefits to both the donor and the recipient. But I also think that at the end of the day, this is going towards basically cure, and it's also providing a new kind of tool and hope, I think, for a patient population where otherwise they would have received just systemic chemotherapy and the survival rates would have been very poor.
Wow. That's very, very promising and definitely hopeful for all of us to hear about. I'm wondering if there is anywhere that if people were interested in learning more about the research or the project that they could go and read about.
Yeah, so it should be listed on the UHN website. So I think that's always a good toolkit. And then I think the end game, of course, is to make sure that more healthcare providers are also aware that this is an option. And I think being able to disseminate our research at meetings, through our paper, I think trying to get the word out that this is a possibility. And I do think more and more places are considering transplant. There definitely is a bit of a shift, but also a little bit of a debate around the role and potential benefit of transplant. So I do think that in the next few years, this is going to continue to be a very hot topic. And I do think that it's going to be a bit more, hopefully, widely accepted.
Amazing. Well, thank you so much for joining me today and for sharing your research. It's definitely hopeful and inspiring to know what you guys are doing. So thank you so much.
Thank you so much for having me.
We hope you enjoyed this episode of the Living Transplant podcast. If you did, please leave us a review and share with your friends. Don't forget to subscribe to Living Transplant wherever you are listening today. If you have any ideas for podcast episodes, you can reach out to us at livingorgandonation@uhn.ca or on social at GiveLifeUHN. For more information about living organ donation, you can visit us at www.livingorgandonation.ca. Thanks to Paula Neves, our advisor to the show. I'm your host, Candice Coughlin. Thanks for spending your time with us.